This is one of interesting case. This picture I have taken from ecg.bidmc.harvard.edu, and I wanted to discuss this ECG because this is one of the interesting case that fascinated me. So what abnormality you can see grossly till now? You might have observed something. So, what is your conclusion? You might be thinking that there is ST depression in V1, there is ST depression in V2, V3, V4 also, and there are low voltage. Everywhere there is low voltage. Keeping in mind that this calibration is normal. You can see here calibration. So the voltage is low, there is ST depression, and if you see this lead you can see there is missing bit here, right? These are conducting regularly, but here there is missing bits, so there is some conduction problem as well. And you are able to see P, right? Here everywhere there is P, but you can see PR interval is prolonged. Here what is the PR interval? Like you can say 200 millisecond, but here it is more than 200 millisecond. If you take this much into account, definitely it is more than 200 millisecond. So this is like Winky batch phenomenon. Here PR interval is increasing gradually and there is sudden drop. So this is 3 is to 2 Winky batch phenomenon. 3 is to 2 means there is 1, 2, 3 P and QRS is only 2. So this is called 3 is to 2 Winky batch phenomenon. If you are familiar with the basic of ECG, you can identify it, right? And here also you can see again P QRS is dropped, and you can see this is the PR interval. You can see here PR again prolonged, here again P is dropped, QRS is dropped, so again 3 is to 2 Wencky wedge phenomenon. But here you can see PR interval is prolonged, this is more prolonged, then this is dropped. So here it is 1 2 3 4 4 is to 3 Wencky wedge phenomenon. So there is 3 is to 2 Wencky wedge phenomenon and 4 is to 3 Wencky wedge phenomenon. So definitely there is some problem in the AV node, right? That's why this is movies type 1 block is there. PR interval is prolonged and then beat is dropped. So these are the basic, or you can say these are the abnormalities that we can judge when you see this ECG. So if I say you this patient was 50-year-old and he had a history of lung carcinoma that was not treated. They denied treatment because it was already in stage 4, and after few years he had presented with symptoms of chest pain, and they did ECG and if they found it. So when you see a elderly male with chest pain, then one of the DD that you can think is like myocardial infarction, pulmonary embolism, right? So can it be myocardial infarction given the ST depression in V1, V2, V3? Definitely, it can be posterior wall infarction, because in posterior wall infarction you will see the depression in the right precordial leads. So there is ST depression and you can see there is conduction problem. So right coronary artery supply AV node right, and posterior wall. So you can guess that right coronary artery might be involved because there is problem in the AV node conduction and ST depression in V1, V2. What else you can think that favors posterior wall infarction apart from these two things that I told you? Can you guess? Here you can see this R wave is little taller in V1, V2. Given this is low voltage, this whole ECG you can see there is low voltage, right? You can see here how low voltage is here. And even this much bigger R wave is greater, or you can say it is high amplitude for V1, V2. So since R wave is greater here in V1, V2, which is not typical. If you see the R wave progression, I have made one video about R wave progression. Actually, R wave is smaller in this side and it gradually increases. So you can see this R wave is not progressing normally. So if R wave is not progressing normally, then it suggests you that it might be posterior wall infarction, right? So that also supports you posterior wall infarction. So definitely this was a case of posterior wall infarction, but do you know one interesting thing? Will he benefit from PCI or thrombolytics? Actually, he did not have atherosclerotic plaque in his coronary artery. Actually, his coronary artery were clean, but this obtuse marginal artery of right coronary artery was compressed by metastatic tumor. So that metastatic tumor has compressed the coronary artery and it has caused this myocardial infarction.